Hi, good evening, everyone, and welcome to ISCP 2021. Today, we're going to be entering the session, Hypertension Updates, the lowdowns on the pressures that clinicians face. Next slide, please. We have an esteemed faculty today. My co-chair is Professor Celso Amodeo from the Federal University of Sao Paulo in Brazil. Our speakers include Professor Weimar Sebba from the Federal University of Goiás in Brazil, and Dr. Jamshed Dalal from the Kokilaben Hospital in India. Next slide, please. Some housekeeping matters to take note of what's on the slide. Next slide, please. There's a live streaming of this particular session, and the ECB EBAC grants CME points for attendees to attend the full session. Next slide, please. You can use the Q&A box for questions, and then we'll try to answer them in the Q&A session. We'll have each lecture deliver the 10-minute lecture, and at the end of it, we will go into the Q&A. So all Q&A will be deferred to the end of the session. Next slide, please. So with that, I'd like to ask my co-chair, Professor Celso Amodeo, to introduce the first speaker. Over to you, Professor Amodeo.
Thank you, Professor Keong. It's a pleasure for me to be here participating in this ISCP Singapore Congress. The first speaker is my friend, Professor Weimar Sebba. He's professor for cardiology of Federal University of Goiás, Brazil, and his talk is about updates in first-line antihypertensive, rationale for change. Professor Weimar, thank you very much for your stay with us today. Okay, please start your presentation.
Great, thank you so much for this kind invitation. Honor for me to take part in this ISCP virtual meeting Singapore. And my talk concerns about updates in first-line antihypertensive, the rationale for change. I have no conflict of interest in this presentation, and I will make all my talk concerning mainly about the recently published Brazilian guidelines of hypertension at the end of 2020. And this document is the basis of my explanation, as I have said. First point I must express is that any kind of treatment will not succeed if we are not correct in our diagnosis concerning, for example, hypertension. So in our point of view, and also in another guidelines all around the world, at least in pre-hypertensive patients, and at least in stage 1 or stage 2 hypertension, we should consider the use of ABPM or home blood pressure measurement to identify the possible phenotypes, for example, white coat hypertension or masked hypertension. So it's very important to be very, very focused on the correct diagnosis, as I have said. Another important point is when start the use of drugs to treat hypertension. So in our Brazilian guideline, that is aligned with the other ones, as I have said, we understand that stage 1 and stage 3 hypertensive patients should be treated at the same moment you have confirmed the diagnosis. For patients with stage 1 at moderate to high risk hypertension, we should start beginning the treatment at the same moment you confirm the diagnosis. And in our point of view, only in case of stage 1 low risk and pre-hypertensive patient with high risk, the treatment should begin with lifestyle change to achieve a healthy lifestyle. and wait no more than 3 months. And if at the end of the 3 months we have not achieved the goals, so the beginning of treatment with the drugs should be considered. Another important point is that goals change depending of the risk of our hypertensive patient. So we have a goal to low to moderate risk, that is achieve blood pressure lower than 140 for systolic, or lower than 90 for diastolic, but we have goals with values under than this, for example, for high risk patients. So this is very important to be attentive to the correct diagnosis, the correct strategy to the beginning of the treatment, and to be always trying to achieve the best goal to our hypertensive patients. Talking about drugs, treatment should be individualized, and the initial choice of medication should be based in the clinical condition of our hypertensive patient. So we must be very, very trying to understand the individual particularities, as for example, the presence of diseases or target organ damage or socioeconomic conditions. The preferred classes of antihypertensive medications for blood pressure control in the initial monotherapy in our Brazilian guidelines are considered to be thiazide or thiazide-like diuretics, calcium channel blockers, ACE inhibitors, and ARBs. In our opinion, beta blockers should be considered as first-line option just in certain situations, but not as a general option. So this flow chart is also in our guideline, and just to stress that monotherapy strategy should be considered, in our point of view, to prehypertensive patients with high risk, or to stage 1 hypertensive patients with low risk, or to the old, or for example, for the old patients with frailty. In all the other situations, the beginning of the treatment to hypertensive patients should consider the use of two drug combination, if possible with single pill combination, because this single pill combination and in patients with hypertension is associated with an increase in adherence of the treatment. Consider two drug combinations. In our opinion, these are the best options to in the most of cases, to make the block of renin system angiotensin, with the option to combine with calcium channel blocker or diuretics. It is important to understand that most of the hypertensive patients, around 80%, will need 2 or more drugs to achieve the goal we have appointed before. And in the line in green here, we have the best association possible with first-line hypertensive drugs. I must stress that the combination of ACE inhibitors with ARB is not recommended, so we should avoid this kind of combination. And as I have said, best combinations are the option of use ARB or ACE inhibitor plus calcium channel blockers plus diuretics. We have published last year a rationale about this combination to achieve the best goal in our hypertensive patients. So the basis of this combination in the treatment of patients with hypertension is this one, as I have said before, and we can proceed with another combination, for example, spironolactone or beta blockers, depending of the risk factors or cardiovascular disease our patient have together with the hypertensive disease. My last slide, and this last slide is just the conclusion of our chapter, of the chapter in our Brazilian guideline. We have here some important topics trying to make resume about this antihypertensive first line rationale. So the preferential medication classes for antihypertensive treatment are thiazide or thiazide-like directives, as I have said. We have also calcium channel blockers, ACE inhibitors, and ARBs as first-line antihypertensive drugs. And these drugs, in most of the case, will need to be used in combination, as I have said. Beta blockers should be considered for specific clinical scenarios, for example, coronary artery disease, heart failure, and another ones. Hypertension treatment may be initiated with 2 drug class combinations. Also in stage 1 hypertensive patients with the risk stratification moderate to high. 2 drug treatment should begin with an ACE inhibitor or ARB combined with thiazide or calcium channel blockers. Hypertensive treatment for right risk cardiovascular patients combining ACE inhibitor and a calcium channel blocker is preferred over combination of ACE inhibitor with thiazide. We have an important trial that demonstrates that mainly in high risk hypertensive patients, the combination of ACE inhibitor plus calcium channel blockers is better in the protection of our patients. When 2 medications combined are unable to control blood pressure, patients should be prescribed 3 drugs, usually ACE inhibitor or an ARB combined with a thiazide directive and a calcium channel blockers. When 3 medications combined are unable to control blood pressure, preference should be given to adding spironolactone as the fourth antihypertensive drug. But we have also some papers showing that, for example, bisoprolol or clonidine could be considered in this case. And hypertension in the fixed combination enable higher adherence rates, and hypertension combined with ACE inhibitor and ARB, as I have said, is contraindicated. So this is my talk. I hope to have achieved our main goals, and I hope to have some minutes later to answer the questions. Thank you.
Thank you, Professor Weimar. I will leave the discussion to later on. Perhaps it is now time to introduce our next speaker. My next speaker is Professor Celso Amodeo, a cardiologist and nephrologist from the Federal University of Sao Paulo in Brazil. Over to you, Professor Amodeo.
Thank you, Professor Keong. It's a pleasure to be here. I thank you very much. In 10 minutes, it's really a hard task to present everything about secondary hypertension, and I try to keep up on time on that. There is no conflict of interest in my presentation. I think before thinking secondary hypertension, it's important to screen before that. You have to find out inadequate measurement of blood pressure. You have to exclude all these topics: white coat hypertension, inadequate treatment, no adherence to the treatment, organ damage progression, and comorbidities and drug interaction. After everything of this has been excluded, we can go on about investigating secondary hypertension, because it's really important when you find out the cause. Hypertension affects 43 million of people in the United States and all over the world. It's the most important risk factor for cardiovascular disease. It's secondary hypertension is 5 to 10% of those cases, okay? And when to suspect about secondary hypertension, when your patient have resistant hypertension, hypertension controlled with 4 drugs or more drugs than that, spontaneous or diuretic-induced hypokalemia, hypertension with adrenal node, hypertension with obstructive sleep apnea, and hypertension with family history of early hypertension or stroke at a young age and in the family, less than 40 years old, cases of hypertension first degree relatives with primary hypertension. And then we have to screening. Testing can be expensive and require clinical suspicion and knowledge of limitation of different tests. In general, principles of this, new onset of hypertension less than 30, more than 50 years of age, or refractive of a treatment like I presented in the slide before. The most common cause of secondary hypertension is intrinsic renal or parenchymal renal disease, renal vascular disease, and also hyperaldosteronism that we found out. Also, one important thing, mainly in resistant hypertension, is sleep apnea. Okay, and the uncommon causes: pheochromocytoma, glucocorticoid excess, Cushing disease, coarctation of the aorta, and also problem with the thyroid. In renal vascular hypertension, we have the 1 to 30%. The most common cause is atherosclerosis, okay, and other causes are fibromuscular dysplasia and the aortic renal dissection, Takayasu arteritis, and other important points. And when you talk about the renal vascular hypertension, we have to think about 3 things. First, it's the behavior of hypertension during the lifetime of the patient. Secondly, how much you have affected the kidney, the renal function of the patient. And also, we have to look if there is any obstruction in the renal artery. So we have a very strict, long scenario in this. And it's important to find out, investigate what happened with these patients. So every time I have to investigate secondary hypertension and thinking about the renal vascular disease, you have to see if your hypertension has changed along the time, if the renal function change around the time, or if you have the obstruction of the artery. It's not only the obstruction that's important. Important is the behavior of the chronic renal, the renal status, and the hypertension. If everything stays stable, it doesn't matter how the size of the obstruction, because you can follow the patient in the clinical setting. But if hypertension changes the behavior, or you have increasing in kidney, in losing kidney function, or the size of the kidney starts to reduce, then it is the time that you have to intervene. In primary aldosteronism, the prevalence is 5 to 2%, and the most common etiology, adrenal adenoma, and it may be asymptomatic, or may have some organ damage, because it's important. And if you wait for hypokalemia, you have this most common, around 15 to 20% of the patients that has hypokalemia. Most of the patients have normal kalemia, so it's important to look after when you have a resistant hypertension. The way that you investigate clinically is to have the ratio of aldosterone and plasma renin activity. Early, there is some tips to how to measure this, but the important is the relationship between the aldosterone and plasma renin activity ratio, also to measure the aldosterone and the 24 hours urine of the patient is another important things. And when you have this aldosterone plasma renin activity above 25 to 30, then this is the way that you have to proceed. Investigate with image to find out if you have any node in the adrenal, and if or there is another test that you can check the aldosterone in the urine of those patients too. Together with the image, you can treat them. The obstructive sleep apnea, that is the most important cause of resistant hypertension. And also, when you have also to think that if you don't control blood pressure on those patients, you have to remember that obstructive sleep apnea can be a cause like I said, is the most common cause in secondary forms of hypertension. Pheochromocytoma is rare, is a tumor containing cells which secretate catecholamines. Young middle age with female predominance in the clinical setting, it's intermittent hypertension, palpitation, sweating. But I could say that in our experience, the most common cause of presentation of pheochromocytoma is resistant hypertension. But this is important thing. Cushing syndrome is also important that we have to look about after the clinical, people with sudden weight gain, truncal obesity, moon faces, and all the other things important that we have to look at. And the coarctation of the aorta is a congenital defect, but can also get in people older than younger people too. And you have always to find out just touching the pulse in the arms, in the legs, and you see sometimes you have a bruise in the chest when you have your clinical. And this if not corrected, you can have to leave the patient to develop left ventricular failure, and this is a very important thing. Surgical correction also today with some hemodynamic procedures can correct this effect. And another important thing is in terms of secondary hypertension, think about the thyroid of the patient, that you can have a hyperthyroidism or hypothyroidism, and this is something that the clinical setting can show you, and also checking the TSH in the blood is important, and treat adequately in order to correct the blood pressure. Like I said, it's so short time for us to present and everything. We have to really quickly, but I think I could give you an idea, and I could conclude that remember clinical diagnostic features of common forms of secondary hypertension when you have the patient with hypertension, and you can see through your clinical setting that you may have a secondary forms of hypertension. Important to appropriately screen patients suspected of having potentially correctable causes of hypertension. Understand the limitation of screening treatment, mainly in patients with atherosclerosis. Like I said, if blood pressure does not control with more than 3 drugs, always think the possibility of a patient have secondary hypertension. But in the first place, be sure that the patient is taking the drugs correctly, okay? And this is the things that I would like to bring to you this morning, and for sure during the sharing questions, we'll be together with you. Thank you very much for your attention.
Thank you very much, Professor Amodeo, for your very nice lecture on secondary hypertension. And now it's my pleasure to introduce our last speaker before the discussion, Dr. Jamshed Dalal, Director at the Kokilaben Hospital in India. Dr. Dalal will be talking about target blood pressure, the moving goalpost. How should the practicing clinician manage the changing targets? Over to you, Dr. Dalal.
I'm going to talk today about target blood pressure and the moving goalpost, and how should we as practicing cardiologists or physicians manage these targets. I have no disclosures for this presentation. Now, we all know that there are multiple hypertension guidelines from various societies, and sometimes many of them are different from each other. So let us look through the guidelines and the targets. Now, why is it so important to have a target? As you can see from this slide, that even small changes in blood pressure can produce significant benefits in terms of cardiovascular disease and in terms of mortality. And therefore, it is very important to fix a target at which the BP should be maintained for varying types of people. Important thing to remember is that the effectiveness of BP lowering treatment does not depend on the starting blood pressure. Additional blood pressure reduction in a hypertensive patient meeting the initial blood pressure targets will produce further benefits. So basically, this means that at whatever level you start, which is a high blood pressure level, and however much you reduce it, the benefits are incremental. But I think I like this definition of hypertension the best. It is that level of blood pressure at which the investigation and treatment do more good than harm. Now, if we look at some of the guidelines, before we go to that, we find that ACC actually changed the definition of hypertension. They considered normal as less than 120, 120 to 130 as elevated, and in fact suggested more than 130 as stage 1 hypertension. So that created a little bit of furor in that time. If you look at the 220 International Society of Hypertension guidelines, they remain what they were earlier: normal less than 130, high normal between 130 and 40, and only above 140 was considered as grade 1 hypertension. So that was the difference between the two. And again, we should also look at the fact that we need to not just look at the office blood pressure, but the 24-hour blood pressure, daytime blood pressure, nighttime blood pressure. So this adds further to the variability in blood pressure recording. Now, if you look at the ACC guidelines, they're pretty much easy to follow. The threshold is around 130, above 130, except in cases of stroke or a very low CVD risk. But the target, as you can see, is very simplified. So I particularly like this because the target for whatever type of patient that you're dealing with is below 130 by 80. The Canadians made it a little more difficult. They said with low risk patients, you should start treating at 160 and the target should be below 140. With high risk patients, you should start at 130 and bring the target to as low as below 120. Diabetic patients, we should bring it to less than 130. And for all others, less than 140. So they made a little variability in terms of normal versus high risk patients versus diabetics. So that adds a little bit to, in my mind, at least the confusion. If you look at the European guidelines, again, very simple. You should start treatment when the BP is more than 140. And in patients who are diabetic, particularly, you have to be a bit careful. If you have patients who are elderly, especially those above the age of 80, then the blood pressure should be treated once it goes above 160. So this is the important thing that you must remember. Again, if you look at the target range, which is what we are talking about today, in the younger age group, we should target to 130 throughout, except maybe in the CKD patients, maybe when you want to keep the blood pressure less than 140 rather than less than 130 because of increasing creatinine and fall in creatinine clearance in patients when you reduce the blood pressure too much. And again, in the elderly patients, you must be careful in terms of allowing the target to be below 140 rather than 130. So all patients below 130 except CKD patients and the elderly patients. So this is again a fairly easy thing to remember. The Indian guidelines are more or less similar. We started treating patients at 140 except coronary artery disease and heart failure, where you'd be a little more stringent in starting treatment. But again, the target remains the same, below 130 by 80. I think the International Society of Hypertension suggested that we should look at these two options, the essential target and the optimal target. The essential target is BP reduction more than 20 by 10 millimeters of mercury, but at least below 150. So this is something essential for every patient of every type of problem. But the optimal would be those that are below 160 to bring it below 130 and above 65 years to bring it below 140. So clearly they used age as a criteria for your target, but everybody at least must be below 140. And the other important thing is that everybody should be within that control within 3 months of starting treatment. Of course, the confusion about how low the blood pressure should be made and whether we should go even lower, as low as less than 120, was brought about by the SPRINT trial, which talked of very intensive treatment below 140, but below 120 millimeters. And what they found was that the primary outcome and death from any cause was reduced when you reduce the blood pressure to below 120. Of course, there's a lot of debate about the BP recording technique, suggesting that what they got as 120 was actually an office blood pressure of about 130. So one presumes that the SPRINT 120 may be equivalent to less than 130. And why is it important not to reduce the blood pressure too low? Because we know from earlier trials that blood pressure has a J-shaped curve. So below a point, you start getting increasing problems because of reduced organ perfusion. So that is one of the reasons why you should not allow the blood pressure to go too low. Now, when you treat blood pressure and control the blood pressure, you should not just look, according to me, at just the office blood pressure. You really should have, at least in some patients, an ambulatory blood pressure monitoring, because you really want to do a proper 24-hour control of blood pressure. So you must look at the 24-hour blood pressure, you must look at the morning surge of blood pressure, you must look at the BP variability, and you must look at the nocturnal fall and nocturnal rise. So there are multiple things that we should do in order to get a much better cardiovascular event reduction. So this is my final slide, which I think summarizes everything. Now, if you look at the American guidelines or the European guidelines, yes, they may be diverging in terms of the indication for starting, but when you look at the target, invariably it is the same. So let us look at the American. They suggest that we should start treatment when the blood pressure is more than 130. In patients who are diabetic and heart failure and who have a high CV risk, I think that is very sensible that you should be a little more strict in terms of the blood pressure control, starting earlier. The European guidelines suggest that we should start treating blood pressure when the BP is more than 140 rather than more than 130. And I think I agree with the 140, especially in the patients who have CKD, elderly patients, and those who had a stroke. So these are the patients who are vulnerable if you reduce the blood pressure too much. These are the patients who benefit by having the blood pressure reduced early. So I think you can go by either 130 or 140, depending on whether you're a high risk patient or a patient of more high risk for side effects. But again, if you look at the targets very clearly, the targets are bring below 130 by 80. So wherever you start, whatever the type of patient, try and aim to get the blood pressure below 130 by 80. There are two things that you should avoid. Don't bring the blood pressure to below 120. And secondly, in those with CKD, elderly, and those who had a past stroke, again, don't bring the blood pressure too much down, and you could be happy with 130 or even less than 140. So this is my suggestion, that you can start at 130 or at 140, depending on the risk of the patient. Bring it down at least to below 130. Be more careful in CKD and elderly, and in no instance bring the blood pressure target to below 120. So thank you very much indeed.
Thank you very much, Jamshed. That's a superb talk, and I think, you know, with all the guidelines out there, this really helps clarify in our minds how we can think about the guidelines. So now we have a panel discussion. My co-chair is Professor Amodeo. So we have some questions first from the audience. Maybe I'll just read this question out here. And I like this question. You know, it's almost a cry of anguish here. So is there no singular truth? Why do different guidelines suggest different targets? If one's country does not have a formal updated guideline, what is your advice? So that is from Doreen, who is on screen too. Maybe I'll just ask any comments, Jamshed? I think that question is perhaps best answered by you, since you.
Yeah, I personally think there's not really too much difference in terms of what target you should reach. I think the target which most guidelines agree is below 130 by 80. So that's the target. If you look at the systolic, I think if you should achieve more less than 130, it is fine. I think you need to make sure that you don't go too low below 120. Now, the sprint trial went below 120, but we must realize that the methodology that they used for monitoring the blood pressure was an automated, quiet, etc., which actually equivalents to about 130 in an office practice. So I think sprint 120 is a misnomer. It should be actually 130 in an office or a setting, which is what we practically use. I think we should be careful in not reducing the blood pressure too much in people who are more than 75 or 80 years, those who got kidney problems, and those who got cerebrovascular accident history. So I think besides these patients, we should bring it down to 130. Patients who are a high CV risk and those who are diabetic patients and younger patients, you should start treating earlier as soon as the blood pressure goes above 130. For the more elderly and the not so high risk patients, you can wait when the blood pressure goes above 140 to bring it down to below 130. So I don't think there is very much difference or very much complicated thinking about targets.
Can I make a small comment on that? And I quickly commented. I think it's important. Most important when you talk about goals for blood pressure control in the elderly patient, is the big problem that we have. We have different patients, so the important thing besides the guidelines is to think about the tissue perfusion. So if the patient achieve reducing blood pressure with the problem with tissue perfusion, then you have to consider to check exactly blood pressure for the patient. Most of elderly patients cannot afford the blood pressure below 140. So, but if they have a good good tissue perfusion, this is the important thing. And you think in terms of tissue perfusion, in terms of concentration, kidney function, left ventricular function, there is a different way clinical settings to find out the tissue perfusion. I think this in the elderly is a very important thing besides numbers, okay?
Well, thank you. There's another question in the chat here, and maybe Weimar or Jamshed can answer this. Why do we need to maintain above 120 for elderly and CKD patients who are on antihypertensives?
I think as this previous gentleman, doctor, has already mentioned, elderly patients, of course, we have to be particularly careful about, especially the very elderly, that is those about 75 or 80 years of age. And we do see plenty of patients today who are 80 or 90 years of age with hypertension who come for us. I think all these patients require a blood pressure in the standing position to measure postural hypertension. And in fact, in all my elderly patients, I tell them to adjust the medication as per standing blood pressure rather than even sitting blood pressure. Because very often the sitting blood pressure would be 150 and they stand up, they feel a little dizzy, the blood pressure drops to 120. So I would prefer in my elderly patients to keep their standing blood pressure above 130 or 140 rather than sitting or lying blood pressure. That's very important. Also, we found that when the blood pressure falls too much, and that was seen in the sprint trial as well, that creatinine clearance begins to fall. So especially in those people who have got borderline creatinine kidney function, dropping blood pressure too much will produce a fall in creatinine clearance. So these two patients clearly need to be very carefully monitored and avoid too low blood pressure. And particularly if I have a patient who's in the 80s, I'd be very happy if the patient is fine to keep his blood pressure between 140 and 150 systolic, not make an attempt to reduce it down. However, having said that, if the 80-year-old patient is very active and well, and he can tolerate a blood pressure of 130 without any problems, I think it will long term, it will do him good. So I think you need to individualize in these two situations. Thank you.
There are some other questions on criteria with diastolic pressure. But maybe before that, there's another question regarding the use of nicotinic acid, and maybe I can direct this to Professor Weimar. The question is in old age systolic hypertension, no comorbidities. People have used nicotinic acid before. Do you have any experience with that, and would it something you recommend?
No, we do not have any experience with nicotinic acid to treat hypertensive patients in any situation. Actually, in old age, with isolated systolic blood pressure, treatment should be, the strategy of treatment should be similar to that of the blockade of renin system angiotensin, and using calcium channel blockers or diuretics. We have good trials with the use of diuretics, for example, indapamide in oldest patients with systolic isolated hypertension. As Celso has said, the problem with this patient concerns about the diastolic blood pressure, because we have to be very, very attentive to do not reduce diastolic blood pressure below 70. So it is very important to be attentive to that. And we do have some experience in this kind of patient with the use of nitrate. For example, in that case, we do not achieve the goal of systolic blood pressure reduction with some good results. But the strategy, I think, is mainly in our, for example, in our Brazilian guidelines, and in another one is the use of this first-line medication, antihypertensive.
Okay, there maybe is a, I think Professor Celso dropped off. I have a question perhaps to all the panelists. And we didn't spend too much time talking about this, but this question relates to isolated diastolic blood pressure elevation. So maybe to Jamshed, are there any specific causes, and will the criteria change? Secondly, to Doreen and Weimar, would treatment differ in terms of what you would use? So maybe Jamshed, if you could take the first part on criteria, would it change?
The problem with isolated diastolic hypertension is that it's predominantly seen in younger people. So you see young people whose systolic is not too high, but the diastolic is, as it's mentioned, 99 to 100 or so. And it's often very difficult to reduce it down, because when you use any drug in these patients, the systolic falls quite dramatically, and yet the diastolic will remain above 90. And I'm faced with a situation where I have no option. You can't make the patient too symptomatic by reducing the systolic blood pressure. So you simply have to accept a little high diastolic pressure. I'm not sure any particular drugs are more useful in one situation versus the other. I try a variety of drugs in young people, including beta blockers and calcium channel blockers and RAS inhibitors. Some of them do respond, but often I see that the diastolic blood pressure may remain high, especially when the systolic is not high and it's an isolated diastolic pressure. So that's my personal experience. I don't know how others treat this diastolic hypertension.
Maybe Doreen, you want to go first? Is there any thoughts as cardiovascular pharmacists in terms of what may serve our younger patients with diastolic hypertension better?
Yes, thanks, Kiki. In general, I think the isolated hypertension mechanism, I think, as mentioned before, is quite complicated, right? It's probably due to the central arterial pressures that's causing that wide pulse pressure. So what has been studied before, as far as I remember, particularly if you had an elderly with isolated systolic hypertension, it's been said that the calcium channel blockers, probably the dihydropyridine class, and potentially the thiazides, which are now, well, I guess with quite a bad name, associated with skin cancers in European patients, are supposed to be the drug of choice for these people. I'll hand the time over to Weimar.
Weimar?
Okay, I fully agree with all of the topics have been talked just now. Just to try to add some information, we have published last year in Journal of Hypertension some evaluation of isolated diastolic, not only in young patients, but also in adult patients. So this is a little bit difficult to treat, because in a young patient, you can do all that have been said here. But in adult, we have to try to reduce this kind of isolated diastolic blood pressure, hypertension. But I believe that the strategy is this one, maybe trying to use low doses of calcium channel blockers or RAS inhibitors as the best option in this kind of situation, and in young adults to be very attentive to this patient, because these patients usually start with isolated diastolic blood pressure, but as the time goes on, there is an increase also in systolic blood pressure. So it's just a question of time.
Thank you.
Professor Keong, it was a really, unfortunately, you don't have more time for the questions, okay? But I think both of the three speakers could give you the message. And I thank you very much to have an honor to share this section with you. I wish you a very good day for you and for everybody. I saw that you have more than 400 people watching us this morning in Brazil and this night with you, okay? Thank you very much. Be careful with the situation all over the world, and I wish you a very good day for everybody. Thank you, Professor Young. Thank you very much, and thank you the other friend speaker from India. Bye-bye.
Thank you. Bye-bye.